After listening to this very interesting presentation, we will continue by Dr. Grace Wright from the Association of Women in Rheumatology from New York to USA. And she will discuss a comprehensive approach to PsA decision making. Please, Grace, the floor is yours.
Today, we will talk about a comprehensive approach to psoriatic arthritis decision making. These are my disclosures. So psoriatic arthritis is a multi-domain disease, and we know that patients can present with one or all of these manifestations, which include peripheral arthritis, axial disease, enthesitis, dactylitis, skin, and nails. We also understand that the efficacy of various cytokine inhibition strategies varies across these domains. And so when we look at efficacy data, we'll look at efficacy with respect to impact on arthritis using ACR70 scores, HAC to measure physical function, X-ray damage. With the skin, we have various scores that we can use: nails, enthesitis, dactylitis, and axial disease has its own measurement using the ASAS40. As we think through the various cytokine inhibition strategies, this will include TNF inhibitors, the IL-17A inhibitors, the bimodals with TNF, IL-17A, CD8086, IL-6, IL-23P19, JAKs, and PDE4. And we'll see that they can really span the gamut of being statistically superior to placebo, or in fact having no difference, or numerically improved but not statistically different. And this is really shown in the color grid that you see here. Now, when we think about the treatment decisions when managing these patients, we have guidance from multiple organizations. And really, this guidance includes that we should consider the non-musculoskeletal manifestations as well as the comorbidities and safety of our patients when prescribing an agent. Our EULAR recommendations state that when managing patients with psoriatic arthritis, non-musculoskeletal manifestations such as the skin, eye, and gastrointestinal tract should be taken into account, as well as comorbidities such as metabolic syndrome, cardiovascular disease, or depression should also be considered. The GRAPPA recommendations include a comprehensive assessment of the relevant comorbidities. The ACR and the National Psoriasis Foundation urge us to take into consideration all active disease domains and comorbidities and the patient's functional status in choosing the optimal therapy for any individual patient at a given point in time. When we think about our patients, we see that they suffer from both non-musculoskeletal manifestations and comorbidities at a higher prevalence rate when compared to the general population. Our treatments also have associated risks, and we'll be reviewing these risks today. And these will include serious infections, candidiasis, malignancy, inflammatory bowel disease, cardiovascular disease, hypersensitivity reactions, depression, and thromboembolic events. And we know that the hypersensitivity reactions can occur across all agents, but we'll see that thromboembolic events are called out for the JAK inhibitors, depression is called out for PDE4 inhibitors, cardiovascular and malignancy, as well as serious infections in the TNF inhibitors, and candidiasis and inflammatory bowel disease called out for the IL-17A inhibitors as well. So what about the non-musculoskeletal manifestations? Let's start with skin. We know that skin is one of the domains of this disease, and our guidance per the EULAR recommendations is that in patients with peripheral arthritis and an inadequate response to at least one conventional synthetic DMARD, that therapy with a bio-DMARD should be commenced, and when there's relevant skin involvement, an IL-17 inhibitor or an IL-12/23 inhibitor may in fact be preferred. In patients with predominantly axial disease, which is active and has an insufficient response to NSAIDs, therapy with a bio-DMARD should be considered, which according to current practice is usually a TNF inhibitor, but when there's relevant skin involvement, an IL-17 inhibitor may in fact be preferred. Now let's look at the efficacy domain, and this is just three exemplary trials looking at the secukinumab compared to ustekinumab in the CLEAR study in psoriasis, secukinumab compared to etanercept and placebo in the fixture clinical trial, and then ixekizumab in its SPIRIT head-to-head in psoriatic arthritis looking at the skin data. And what I've presented here are all the PASI 90 responses showing that there's efficacy across agents to varying degrees in the skin. However, the skin is also a domain for adverse events, and we see injection site reactions occurring in the skin, again with varying rates, so that when we look on the left column where we have ustekinumab, secukinumab, brodalumab, and guselkumab, we see incidence rates that vary from 1 to 2.4% across these four products, with secukinumab showing less than 1% ISRs in its trials. On the right, we see the TNF inhibitors as well as ixekizumab, and there we see a more variable rate. Now, this may be an area that is consequential to many patients. The gastrointestinal tract becomes a very important site for multiple reasons. And what we see here per the EULAR recommendations is that TNF inhibitors and IL-12/23 inhibitors, in the absence of axial involvement, are in fact preferred for patients with psoriatic arthritis with concomitant inflammatory bowel disease. When we look at the incidence of inflammatory bowel disease adverse events across an adalimumab population, and this was a long-term pooled data set, and here we're going to look at the exposure-adjusted incidence rate, which is the bottom line in this grid, across multiple populations. And I'm going to focus your attention on the numbers in the red square, which look at ankylosing spondylitis, non-radiographic axial spondyloarthritis, psoriatic arthritis, and peripheral SpA. And the rates for the exposure-adjusted incidence rates are 0.7, 0.5, 0, and 0.8 in this population. When we then look at the IL-17 and IL-12/23 axis in this pooled analysis, separating ulcerative colitis and Crohn's disease, we'll see here on the left, this is going over 5 years for ulcerative colitis, with secukinumab, 300 milligrams being shown in the green squares, and any secukinumab being shown in the brown diamonds, that the rates here vary from 0 to 0.4. Etanercept is present as that sort of tan circle, and that comes in at 0.3. Ustekinumab in the X at 0, and placebo coming in at 0 as well. The numbers are quite similar across the Crohn's disease population, with secukinumab having 0.1 for any dose, including the 300 milligram dose, and all of the other rates rounding down to 0 for the other agents as well over the course of 5 years. When we then look at secukinumab itself and looking at the inflammatory bowel disease with secukinumab-treated patients in clinical trials across the 3 approved indications, which would include psoriasis, psoriatic arthritis, and ankylosing spondylitis, we see the rates here compared to the background rates of 0.1 for psoriasis, 0.1 for psoriatic arthritis, and 0.4 in the Crohn's disease population, and 0.1 for psoriasis and psoriatic arthritis, and 0.2 in the ankylosing spondylitis for that risk of ulcerative colitis. Now, as a caution, there is a warning and precautions for the use of secukinumab in patients who have active Crohn's and ulcerative colitis, and it should not be prescribed for those patients. And just as a reminder, that patients with these 3 diseases, whether it's psoriasis, psoriatic arthritis, or ankylosing spondylitis, are at a 1.3 to 4-fold increased risk of IBD compared to the background population. So it is one of those things that we need to check for with our patients, both before and after prescribing therapies. The post-marketing surveillance across these 3 populations in the secukinumab treated group, and this is pooled data through 2018, shows a steady and flat incidence rate of 0.2 to 0.3, so no increase in incidence rate seen with usage of the agent. Let's talk about eyes as another non-musculoskeletal manifestation. And we understand that uveitis is one of those areas that can impact our patients. And the recommendations per EULAR is that in the presence of uveitis, a monoclonal antibody to TNF may be the preferred first and second by a DMARD because of the approvals obtained for those agents. And again, not all TNF inhibitors are approved for the treatment of uveitis. But when we look now at the presence or the occurrence of uveitis in patients treated with secukinumab throughout the clinical trial program, again looking at the pooled data through 2018, we'll see that the exposure-adjusted incidence rate of uveitis as an adverse event in these patients for psoriasis was 0.01, psoriatic arthritis was 0.1, and ankylosing spondylitis 1.2. And again, as a reminder, that incident uveitis varies across spondyloarthritis according to the subtype. Now let's talk about treatment-related safety risk, and we'll start off with infections. We understand that various diseases respond differently to various cytokine inhibition strategies, and that these strategies themselves carry incident risks because of the impact, number one, on various cells involved in host defense, and more specifically, whether it's attacking viral, bacterial, or fungal mediators. We may see differences across risk profiles with these various cytokine inhibition strategies. So when we look at a pooled long-term anti-TNF data, and this really comes from the 77 RCTs of adalimumab, looking at just under 30,000 patients, representing 56,916 patient years of exposure. Starting from the bottom, we'll see that the opportunistic infection rate varied from 0 to 0.4. When we look at the diseases that we're focusing on today, the psoriatic arthritis, non-radiographic SPA, peripheral SPA, and AS, those numbers varied from 0 to 0.1. Tuberculosis comes in at anywhere from 0 to 0.4, and the overall infection rate varies across these different disease states, with the highest being seen in Crohn's disease, and really in the inflammatory arthritis, anything going up to just under 3%. And in fact, esophageal candidiasis was the most common serous opportunistic infection, and of note, no events of serous oral candidiasis was reported in any study, and no serious opportunistic infections were reported in psoriasis, hidradenitis suppurativa, ankylosing spondylitis, peripheral SPA, and psoriatic arthritis studies. What about the incidence rate in patients treated with secukinumab? And we're going to look at the psoriatic arthritis and the ankylosing spondylitis populations. And again, this is over the course of 5 years. On the top, you'll see serous infections. On the bottom, you'll see candida infections. And the rates are essentially flat for serous infections, averaging around 1.4 to 2.2 over the 5 years for PsA, and anything from 0.7 to 2.2 for AS. With candida infections, there's a numerical trend towards 0, but again, these are overlapping confidence intervals, so really no significant difference seen in candida infections over the course of 5 years for either cohort. Spontaneously reported new latent TB infection following treatment was uncommon, and in fact, no active cases of TB or reactivation of baseline TB were reported. Cardiovascular disease is of great concern for our patients. And here we're going to look at the cardiovascular risk in psoriatic arthritis patients treated with DMARDs. And this is using large cohorts out of the UK and Canada. And here we see really no difference across these populations. Of the general population as a background reference, psoriatic arthritis patients treated without a DMARD and psoriatic arthritis patients treated with a DMARD. When we look at the Canadian population, no difference was seen in MACE events with TNF inhibitors versus DMARDs versus untreated, and so there was nothing that popped in these populations. When we look at the incidence rate of MACE over time in clinical trials with secukinumab, again having comparatives for placebo, etanercept, and secukinumab shown here, we'll see that the background rate for the placebo-treated arm was 1.3, and all of the other arms were anywhere between 0 and 0.5 over the course of the 5 years. Again, pulling out the psoriatic arthritis and AS, we see that the rates there varied from 0 to 0.7 for PsA and anything from 0.2 to 1.1 for ankylosing spondylitis. So MACE is an important adverse event that we need to be aware of and need to check before and during therapy. Malignancies also are always a concern for us. And here we're looking at the incidence of malignancies with anti-TNF therapy in clinical trials across multiple indications. And this goes back again to the adalimumab data set. And we see here that for all malignancies, the standard incidence rate was 1. For lymphoma, it was also 1. And for non-melanoma skin cancers, it was 1. So there's some variability, but all of these lines cross the 0 line, the 1 line, and so there's no increase in the standard incidence rates. Again, when we go to register data, and we can look at the Danby and ARTIS registries to compare those patients treated with TNF inhibitors, comparing them to TNF naive, comparing the TNF treated patients with the general population, and this again is a psoriatic arthritis cohort, or comparing TNF naive patients who have psoriatic arthritis comparing them to the general population. And you see here again that these all hover around the one line. And so our risk rates are essentially one. So no increase that was noted that was significantly different across any of these malignancies. Looking at the secukinumab trials, again, this is pooled data through 2018, looking at the psoriasis, psoriatic arthritis, and ankylosing spondylitis programs. What you see as a reference in the dashed horizontal line is a general US population with an exposure adjusted rate of 0.95, and the malignancy rates across these three populations, in fact, was 0.9, 1.0, and 0.5. So no increase seen in malignancy in these clinical trials across the 5 years. Immunogenicity becomes a great concern for patients on therapy. And so we can look broadly across the data presented in clinical trials, understanding that these are different assays, different immunoassays, different methodology for all of these products. So we can simply show ranges, knowing that this is not a comparative analysis. So with adalimumab, we see rates of 0 to 54%, and that was culled from 80 trials, shown in the parenthesis. Certolizumab from 14 trials, we see rates of 3 to 37%. Etanercept gives us rates of 0 to 13% out of 37 trials. Golimumab 0 to 19% out of 22 trials, and infliximab 0 to 83%, and that was culled from 110 trials. Ustekinumab 1 to 11%, culled from 15 trials, and secukinumab with the 14 trials, 0 to 1% were the immunogenicity rates that were seen. So this is really the frequency of anti-drug antibody formation that was noted. Ixekizumab presents both the psoriasis and psoriatic arthritis, and we'll see the treatment emergent anti-drug antibodies coming in at 17.4% in the psoriasis data set and 8.8% in the psoriatic arthritis patients. And of these, there were a proportion that had neutralizing antibodies, but in fact, this did not affect the long-term efficacy of ixekizumab. When we look at the same data with secukinumab, we see low rates of immunogenicity. We're coming in at less than 1%. And in fact, of those patients who had neutralizing antibodies, there was no loss of efficacy that was seen associated with these treatment emergent anti-drug antibodies. So in summary, what we have shown is that patients with psoriatic arthritis have a higher incidence of non-musculoskeletal manifestations as well as comorbidities compared to the general population. And in fact, the presence of these non-musculoskeletal manifestations, as well as the various comorbidities that our parents experience, along with the safety profiles of the psoriatic treatments, should be considered when initiating a new biologic. Our goal is to get the right drug to the right patient at the right time with all of these considerations taken into place. And finally, I've also shown you the data for IL-17A inhibition with secukinumab, demonstrating a favorable safety profile over long-term treatment in patients who have either psoriasis, psoriatic arthritis, and ankylosing spondylitis.
Grace, I'd like to ask you, how do you assess the presence of comorbidities in clinical practice? How do you do this yourself?
So it's very important in our patients to assess comorbidities in clinic because they present with so many things that can confound care. So I routinely assess for depression. That's a very important comorbidity that can be missed if we don't ask about it. There are various screening tools that we can use for depression, but simply asking the patient about how they feel, they are often very willing to volunteer data about their depression. And then we routinely check for the presence of hypertension, hyperlipidemia. That's really easily done with checking the labs. And all of these patients that at some point have a cardiovascular risk assessment to see whether or not there's incident heart disease or signs of coronary artery disease as well. Most everything else is manifest in our physical exam, but these are areas that we can miss. And I think it's very important for rheumatologists to keep an eye on these areas for patients.
And which is the most important extra-articular manifestation when making treatment decisions?
So when we think about the extra-articular manifestations, skin, eyes, and guts really pop into mind. Patients usually know when they have uveitis, it's either visible or it's felt. But when we think about inflammatory bowel disease, many patients may mistake this for irritable bowel. And so it's important for me that I make sure that we're not missing the bowel manifestations. And so the gut and the eye really become my two critical things for choosing a treatment decision. The skin, obviously, is going to be something that patients are going to lean towards, because if they have significant skin that's bothersome, even if their musculoskeletal domains are not as worrisome, they're going to want to do something about their skin as well. So that becomes an important domain when we're making decisions.